So what will you start?
Sir, boleh tak jalan?
So start with gait. Okay. So what can you expect? What can you expect? Anticipate with the gait in the cerebellar examination?
Broad-based gait
Yeah,
and
broad.
staggering.
Staggering. It will walk like as if you're drunk. Okay, ataxic, such as if of ataxic gait. Okay. So first you ask them to assess normal gait. Ask them to walk back and forth, and you might want to walk along with the patient because they will be unstable. So there's a risk of them falling off. Right? And then you assess tandem gait. So what is tandem gait?
Cik boleh tak jalan?
So this tandem gait. So this is to exaggerate. This is a very sensitive test to exaggerate the instability. So they won't be usually able to. You'll have great difficulty to actually execute a tandem gait. Then you want to check for Romberg's test, proprioception. Remember, proprioception is not specific to cerebellar lesion. It actually tests for the dorsal column lesion, okay, spinal cord. But we will still do it. So just remember that Romberg's test you're doing is not specific to cerebellar lesion.
Cik boleh macam ni?
First step is bring the ankles close together,
Then tutup mata.
then the hands close together, okay, and you make sure you safeguard the patient. Ask him to close the eyes, and if it's positive, he will sway off. Then we come to the, so gait is done. Next we come to the head. So what do you want to inspect in the head? So number one, speech, for staccato speech. And so what do we mean by staccato speech?
Very hard to pronounce the word.
It looks very individualized, like they can't complete a word in its fullness. They will separate each sentence. Like, so what word can you use to?
Wilayah persekutuan.
So usually in textbook will be British Constitution, but in Malaysian setting you want to use Wilayah Persekutuan will be a good choice.
Cik boleh sebut wilayah persekutuan?
Wilayah persekutuan.
Yeah, so it will sound slurry and it will sound. This is what we mean staccato. It will be very staccato. That's what we see. Then nystagmus. So how will you check on nystagmus?
Nystagmus, H.
Yeah, so to first ask the patient to look straight into you, okay, and make sure that he doesn't move the head. So at times you might even want to stabilize the head. Okay, then you ask him to observe the tip of the finger, okay, and move in the H direction. And just cross over and do it on the other side. So look for nystagmus. Then you want to look. Then we go to the upper limb. What do we have in upper limb?
Pronator.
Pronator drift. So how do we assess pronator drift? Just just ask him to raise and extend the elbow, and just close your eyes.
Tutup mata.
So the test will be positive the moment you see an upward lift of his limb. Okay. In cerebellar, remember it's always ipsilateral. So the affected side, if it's right, it means the right side is lesion. If it's always ipsilateral, then rebound phenomenon. So what is rebound phenomenon? Okay, same thing. So you ask the patient to maintain. So let's say this is the position of his forearm. You ask him to maintain the position here while I try to push it down. Okay, so he has closed the eyes. You try to maintain your hand at this position. Okay, so when I push, when I push down and leave my hand, if it's normal, it will come back to the actual spot. If it's having rebound phenomenon, it will go beyond the default position of his hands or forearm. Then tone, reflex. So how can you do tone? So hold the elbow and hand, and then you, like as if you're shaking hand with him, then you just pronate, supinate, flex and extend. Okay. Do it on the shoulder joint as well. Okay. And do it on the contralateral. Then reflex. So what reflexes can you check? We have seen these many videos. So we want to check for supinator reflex. So how will you position the patient? Left on left, right on right. So patient's left forearm on your left forearm, and then you just look for supinator reflex. biceps. Here you want to expose to look for the contraction of the muscle. Okay, and then of course you can look for tricep. That will surface. And then what do you look for?
Coordination.
Coordination, yes. Next, coordination, finger to nose. So how will you do that finger to nose test?
Sentuh hidung kecil lepas tu sentuh jari raya.
So the better way will be, ask the patient to do this by having the shoulder abducted like this. Okay, and this his shoulder abducted to about 90 degrees, and then yes, touch the tip. Okay. And should the examiner change the position of the fingers, it should be only done before the patient leaves the finger off the nose. So it shouldn't be changed the moment the patient has already moved the finger off the nose. So it should be done before. Okay, that's finger to nose. And next is intentional tremor. So what do we mean by intentional tremor? Do not confuse it with frying tremor. Intentional, so it comes with an intention. So take a pen. Okay. So ask the patient to touch and hold the pen. Touch separately, hold the pen separately. Touch the tip of the pen. They won't be able to do it. Touch, ask him to hold.
Cuba pegang pen.
So this tremor comes when there's an intention to specifically grab something. Then after that, this
Diadokinesis. This diadokinesis.
yeah. Okay, so how will you ask the patient to do that?
Cik boleh bawa macam ni. Tangan yang sebelah.
So the common mistake is people demonstrate it as just a rapid pronation and supination. No, you have to lift up. So it should go up, down, up, down. It shouldn't be like this. It should actually go up, down. Okay, up, down. Then after that, what do you do?
Lower limb.
Yeah, lower limb. So lower limb, you just check for tone and reflex. It is already in the video where we have the lower limb neurological examination. Check for tone. So it will be hyporeflexia. Cerebellar lesion, it will be hypotonia, hyporeflexia. And then you can do heel to shin. So how will you do heel to shin?
Cik boleh baring. Cik ambil kaki ni, lepas tu sentuh dekat sini sampai atas. Okey.
Okay, buat boleh buat.
Atas. Okey. Lepas tu lagi sekali.
So we are silk kemarin pun berikan.
Okey. Okey. Macam
Okay, buat lagi.
so
another common mistake is a lot of them will just extend and flex the knee over the contralateral limb. So this shouldn't be done. It should be heel to shin, lift, go back to the heel, go back, heel to shin, go back. Okay, not heel to shin and shin to heel. It's only heel to shin. So one direction, go back to heel, one direction, go back to heel. It shouldn't be in this manner. And you will conclude the examination by telling that you will complete an upper and lower limb neurological examination and cranial nerve examination.
okey, cikgu masih. Okey.